Cape Town, a metropolis of white sandy beaches and stunning mountains. However, a dark illness plagues people in the Brooklyn Chest Hospital. Selwyn Joyce has been living in this facility for 20 months. He was initially diagnosed with MDR-TB. He had poor compliance to the treatment. He was a substance abuse user of tic and cannabis at the time and was living with an aunt and 3 other adults in a flat. XDR-TB treatment was started in June 2013 while he was in Paulsmoor prison. He was admitted to Brooklyn Chest Hospital in September 2013. He had good treatment adherence with few side effects. However, sputum results remained positive despite being stable on treatment. X-ray findings showed active TB disease. After 18 months on XDR-TB treatment, his case was presented to the committee with the outcome that benefits from further treatment was highly limited. Discharge to an isolation setup at home was not possible. With no other options available, Selwyn Joyce was kept at the hospital.
I've been working at Brooklyn Chest for the last 3 years in the male wards in patients that have got pre-XDR and XDR TB. And I guess my overwhelming experience has been, one, just the complete social deprivation that most of my patients have experienced. And number two, the sadness of watching treatment proceed without being able to get my patients better. So we have very high death rates. And I'm hoping that that's changing with new drugs.
I don't know what was the feeling because I never thought it was something that kill you. First time I was an MRI, wheezing testing and my lungs was holes. The worst thing for me and my TB is injection. Because the injection make things on you because they make you deaf, your eyes, you keep in your, whatever in your body, it affected you. And that's the most important thing in injection. But for 2 years I was an injection. And that's, maybe the people not working on me, but injection helped me. Something must help.
You know, I think it's debatable how we got to this point with an epidemic of pre-XDR and XDR TB. On the one hand, there's been patients that have defaulted their medication or not been adherent to their medication for various social reasons, but also for reasons like drug abuse. And then there's been patients that have contracted this type of TB as a primary TB or it's been transmitted. But then also there's many that would say that we've been running an MDR regimen which has been inadequate and has also contributed to where we are now.
I believe there's a cure.
Okay.
And I believe if you believe in yourself, you can cure yourself.
Look, I think we're learning and we're moving forward. And to say that we have done well when we have a rising epidemic of drug-resistant TB is perhaps a little bit too complimentary. But I think that we are expanding the program. We are learning from our mistakes. More people are getting onto treatment sooner. Things like decentralization have been pivotal. Gene Expert has been pivotal. And being able to try and cope with these new strains of highly drug-resistant TB. So I think we're doing well.
What are we going to do about our default rate? Because currently we're sitting with a major problem, which is our default rate. When do our patients default? They do not default while they're still on the initiation phase, which means they have to take an injection for 7 days a week, 6 months of the year. They do not default on that stage. They, however, do start defaulting when they start feeling better.
Mr. Joyce has been one of, I guess, many patients who landed up staying at Brooklyn for quite some time and whose treatment hasn't worked and who's run out of options. I still am hopeful that we're going to be able to find a regimen for Mr. Joyce. I don't like to sort of shut the lid on hope for these patients. But the truth is, he's been here for 20 months, you know, out of his community, away from his friends and family. Going back to his community has its risks. There isn't the physical place for him to stay and where he can safely not infect the members of his family and his community.
But if you can create a better drug, then maybe can help me. As you know, follow one after me what's coming in coma. The new drug now is helping people 2 months, 3 months to go home.
Oh,
I'm 2 years here. The old drug is still up, it's still old drug.
Okay.
He come for the first time, I give a new drug, he's going home.
Okay.
The tip is killed by him once and for all.
I believe that there is hope for patients whose treatment hasn't worked. And I also believe that there is hope for the epidemic, and that we need to start building capacity to manage patients like Mr. Joyce, both in facilities like Brooklyn and out in community-based facilities or in their homes.
My sister brought me up. And I thought all the time that's my mother.
He's my little brother and I'm the eldest. I haven't got parents anymore, so I have to stand by him.
Every problem I got, if there's a solution, I go to her.
Okay.
Yeah. Everything I need, I go to her.
Others don't care because he got that sick and he must stay away.
Before this thing, I must keep myself alive. Because I don't want to break my shoulders out.
There's always hope. If you pray, there's hope. Because I had 2 children that was MDR, and there was hope for them.
It's become sort of clearer to me why our patients whose treatment has failed are quite significant in number, and many patients in my wards die from their illness.
Women know myself, and Joyce, yeah. So,
Okay.
I miss my old life.
Uppington, a town of contrasts nestled on the banks of the Orange River. Here we meet Mina Titis from the Wegdraai community. Mina Titis first received TB treatment in 1999 and got cured. She developed MDR-TB in 2010, which was later confirmed to be XDR-TB. She was on XDR-TB treatment for 18 months, but she failed XDR-TB treatment despite good compliance with treatment, participating in the rehabilitative sessions and a good home support system. The Northern Cape DRTB Treatment Review Committee reviewed her case and strengthened her treatment regimen, allocated her with a home-based care supporter, and also facilitated provision of a disability grant.
Mina Titis came in 2010 as a newly diagnosed XDR, and we treated her in the drug-resistant TB unit in Gordonia, in the old Gordonia. She was in the hospital for almost 18 months, and after 18 months she failed treatment, so we decided to present the case first to the multidisciplinary team in our hospital, which decided to present her as a treatment failure to the provincial review committee. After long discussions in her case, we decided she might have a second chance with new drugs like linezolid and clofazimine that at that time came as a new drug in our national TB program. So in December 2012, we started treatment with her, and after so many months she had quite a hard time. She was developing side effects, but we managed to treat them. And then we reached the finishing line in August 2013.
It was very difficult for me to see Mina suffering, to drink the pills. Because it was about 20 pills she must drink per day.
My feet and my hands, I When I drink for a time, I can't take things. It fall out of my hands. When I boil water, when I take the iron, the kettle, it fall out. And when I take a thing, my hands, it fall out of my hands. And when I can't walk on my, so I must walk on my heels. But later on, I never can sit on the toilet alone. The people must help me to keep me so that I can go to toilet. I can't sit alone. And sometimes weekends when I go to home, I don't want to be in the home. I was afraid I going to give them that sickness. Then I stay the most time outside. I don't want to be inside. Just when I go bath, I go in. And the whole day, the most of the time I was outside. The most time I was thinking about my child. He was small, and that's why I put my whole my samenwerking. Cooperation to do what I can do. Even sometimes it was dangerous for me to do it, but I was doing it for him.
I was so worried. I'm so worried. Will Mina survive this treatment? And then I encourage her every day how to manage Mina to drink her pills and so.
After she had a sputum converted, we decided it's time to discharge her to the community to continue treatment there because it was too long in hospital. So we looked for support from the multidisciplinary team, from the community, from the sister at the local clinic, and from the CASIPO program. Then we managed to get these injections done in the clinic. And the sister visited her every day, the DOT supporter. And me, myself, visited her on a monthly basis at her home.
It was like, I can't believe it because I did come through a tough time. That Friday, the week comes daar by the old hospital. The doctor told me I'm finished today with the tablets. I was on August. I was very happy.
I was very, very happy to see her overcome this.
I didn't think she's going to make it. The last time I sent her to hospital, I thought I greet her. And everybody was crying because Mina was one of the patients that was so positive about feeling better and committed. And one of the few patients I met that has that courage to go through that she went through. And when she come back with that new results of the new medications and the challengings about that, it was very good news, and I think for all the partners involved, it was a good thing to tell Mina, listen, you are cured now.
My message for you is that don't push sick people like this away because they also human beings like other people, and they got also feelings like other people. It is sometimes very hardly. I know sometimes. Nobody tells you to go and get the sickness, but it's hard to push somebody away or treat him like an animal.
Moving forward in the program, we need a lot of support. We need support for palliative care. We need support to be able to give injections for the patients outside in the clinics. With this new coming of the bedaquiline and the linezolid in our TB program, we actually need support outside, that the patients can be able to be treated outside in the communities.
USAID TB is highly motivated and fully involved as a strategic partner to National Department of Health and all the provincial Department of Health. So our message as USAID TBK2 is to you all delegates to say that there is hope. If we consider where we're coming from, a lot of progress has been made, but we know we still need to do more. So basically, we want you as delegates in this conference to consider yourself as a stakeholder, critical one, to ensure that all the discussions becomes robust, bringing your expertise in the field to talk to this document that will be developed at the end of the day, because this document, we should own it. It should be part of what we're going to be doing on a daily basis, trying to improve quality of care, more especially to those patients who are not responding to treatment.
To all conference delegates, I welcome you. I wish you well. This conference is a very important one. Integration of palliative care into MDR-TB care is critical. It's been long overdue. We're bringing in experts who will bring a message, but I'm sure you, as delegate, you have a lot of experience. You do have expertise. You know your work environment very well. We're expecting a policy document, a guide that will help us manage better, because we know that despite our numerous achievements, we still have a long way to go in terms of managing palliation amongst our patients. We know that a lot of patients out there live without, proper guidance, proper care, and we need to improve on the care of patients where we cannot cure. Our responsibility is always to take care. And I'd like to thank you for the hard work that you've done in the past. Our treatment success rate for MDR-TB is increased to 49% for the 2012 cohort. That wouldn't have been possible without your contribution, as well as our partners. So I thank you, I wish you well, and you're welcome. I hope you'll have fruitful discussions during these 3 days. Through the partnership with URC, we've had the doctors trained, the clinicians trained by Dr. Caminero. This training has had a huge impact in this country. It's a pity we haven't done a scientific evaluation, but before 2009, there were a lot of publications which showed that doctors in the country didn't know exactly how to treat MDR-TB. So we made effort really to make sure that clinicians are trained, So there has been a massive progress. Decentralizing the care, which was initially doctor-driven, highly centralized, has been a massive progress. In 2011, before the policy was sanctioned or signed by our DG, we had 17 treatment sites. To date, we're talking 298 treatment sites. That is a massive achievement in a short space of time in terms of scaling up, increasing access to care, because that's really what matters, taking care to where the people live.
The story shows that palliative care is a critical component in the continuum of care for people suffering with TB. Never lose hope.